We're good to go, sir.
Yeah. Good evening, friends. Welcome to this Tuesday webinar sessions from Yashoda Group of Hospitals. We try to bring some topics of interest to all of us. I was privileged and maybe honored to meet Dr. Piyush Mathur, who is a senior consultant and was the course director in Cleveland Clinic, United States. And he was postgraduated, and then he moved to United States for his further career growth. He is a good friend of many of our senior colleagues and leaders in the country of India. And we are privileged to know about not just his clinician part of critical care in Cleveland Clinic, but also as an expert in AI development in critical care. So he actually owns a company called BrainX, which actually is a brainchild of him with his colleagues and partners, actually, which is developing AI-based critical care services, or probably it will be a futuristic way to go forward. And we are trying to actually bring him onto this platform so that all of us who are actually knowing pieces and bits of AI in critical care will get updated. It is a privilege and honor to have Dr. Piyush Mathur on board. Thank you for joining us. We welcome you.
Yeah, thank you, Dr. Kola. And I truly feel honored to be part of this exciting webinar series. And first of all, I would like to thank you, your team, many at Yashoda Hospital, including the leadership, the CEO over there and all, who saved my mother's life recently. She came in very sick without using AI, with using just your real intelligence. You avoided her getting intubated. You avoided her getting sicker. And just recently, she walked a kilometer and she's not on any oxygen or anything. So she did great. Thanks to your care. I'm privileged to be part of this.
Thank you. Thank you, Dr. Piyush, for those kind words. It's over to you for the presentation.
Sure. I just want to make sure you can see my screen.
Yes.
All right. So I'm going to talk about AI in critical care and perioperative medicine, partly perioperative medicine, because if you think about a lot of patients that we take care of in the ICU are post-op patients, and we do take care of them in many ways on the floor or as an extension of that too. So I'm going to talk about the current state of AI, talk about what are the current trends in general, what can we learn from other specialties and what's happening there, because if you think about it, it's not just critical care. A lot of applications that are being developed for other areas are also being utilized in critical care, and that's why that's important to understand that. And as I said, talk about some examples of AI applications, critical care and perioperative medicine. A lot of people think, well, that is the future. No, it's present. That's the case I'm trying to make today for you. So let's start briefly about AI. And many people think about AI as a homogeneous entity. It is not. Just like healthcare, there are all these different specialties like cardiology, anesthesiology, critical care. Similarly, AI also has a lot of different subspecialties, the machine learning, the deep learning, and the neural networks. And the whole idea behind AI in 1950s originated with the concept that let's try to mimic human intelligence. Let the computer mimic human intelligence. But there are many, many different aspects of AI. It's not a homogeneous entity. That is a common myth. I wanted to clarify that. Many people think of AI in two different ways. One is the base of AI is a model. And many ways to train that model is what you see on the left, that is the supervised learning, where you feed it with the data, and the data has to have some labels. So as you see on the left in the yellow, you can see that there are these animal photographs, and then there are the labels, which is naming those animals like duck or not duck. And then you train the model. And at the bottom in that yellow, what you see is the next time that you show the model an animal, it is able to predict that it's a duck. Now, there is another way to do this, which is unsupervised learning, where you show the model a lot of different animals, and it will cluster these animals based on the patterns that it finds. So if it's got two legs and a beak, then it's probably one set of animals, and you can say like these are birds. Or if it sees like two long ears and four legs, then it's going to say like it's probably a different animal compared to the one at the bottom. So there, classically, it's described as in simple terms in these two different manners. And there are many other ways to classify artificial intelligence. I'm not going to get into the deep technical parts of it. Now, I do realize that there are always many people who feel like, why do we need AI? I think it's a black box. People don't believe in it. People don't think that it is needed. So let's play a AI game over here. So if I were to show you this picture and ask you, is it a male or female? I'm pretty sure a majority of the people over there with a high degree of certainty will say this is a male photograph. How about this one? Is it a male or a female? Again, looking at this photograph, based on our experience, I think a lot of people would probably lean towards saying that this is a male. How about this one? Male or female? Whose fundus is it? Well, that's where AI is helpful because it can look at certain patterns that we traditionally don't look at or we traditionally cannot infer from. And I'll give you more examples of this. So in this particular research publication, they looked at the fundus and they were able to look at a lot of different patterns to predict different outcomes. So whether it's a gender, whether it's age, and you think about, we do hemoglobin A1C to look at the glucose trends or the glycemic control trends over time period. But we don't do the same for blood pressure. You end up seeing patients with atherosclerosis or with end organ output. Here, they were able to look at the systolic blood pressure with a great degree of accuracy, and they were able to predict also if the patient is likely to suffer cardiac event, looking at the fundus image. So there are traditional things that we do look at, but we don't necessarily look at different patterns. Now, going to critical care, this is something that we published in 2019. Even in 2019, we saw this trend that there was an increasing trend of publications in critical care research. And there was a lot of enthusiasm related to it too. So we started looking at these trends overall. We started looking at healthcare publications overall. And for the last 5 years, we have been publishing a year in review where we take PubMed search, we look at prior years publications, and we try to look at what are the patterns for different healthcare specialties. And this is freely available through ResearchGate or through our website, brainxcommunity.com. And what we have found is that every single specialty has had increased amount of research work year over year. So much so that we can't sift through this manually. So what we started doing was, as you see on the top, we built a neural network where we feed in all this information and it helps us get this information analyzed. So we are using AI to analyze AI in healthcare publications. And of course, a lot of this till recent times has been based on image-based data. Now, this is just recent. We published this in February. So this is 2023 and prior year's trends. And again, another example where you can see every single specialty has a growing trend of research related to AI in healthcare. Where does critical care appear in this? So you can see critical care is still like way behind. And I think that's the defined opportunity for us. And I'll give you some more examples of that. Imaging, that is radiology or image-based specialties like ophthalmology, oncology, cardiology, they have been the leaders. But now with certain new sciences in AI, I think our opportunity is ripe to take over the lead. The new sciences that I was talking about, you might be familiar with, is the ChatGPT. ChatGPT caught a lot of people's imagination. So if you think about the personal computing era, when Steve Jobs, a few decades ago, introduced personal computing to people, he made the personal computer say hello to people. And that's where people started relating to personal computer. Prior to that, it used to be these big IBM mainframes, only the technologists could use those. But Steve Jobs made these personal computers available to masses and made them user friendly. The same thing has happened with ChatGPT, I feel. Now AI is saying hello to people. And you can see how many people are using ChatGPT these days. It's one of the fastest adopted application in the history. So AI is getting to consumer level very rapidly. A lot of people think of this as like, maybe I don't understand, it's a black box. I don't know if it's even a science, but I want to show you what's on the back end of this. What's on the back end is a very significant science. It is something that is extremely complex, and it's based on deep statistics. You can see the equations over there. This is the basis of what gets you the chat GPT responses. So there is a deep technique. Again, I'm not going to go into the details of this, but there is a significant amount of science that goes into this, which is produced by these large companies or large universities. There are these large departments that are continuously working on improving it. So that's why you are seeing this work come into place. And again, as I said, chat GPT, or generally talked about large language models, are causing excitement across healthcare. So a lot of different specialties, they are very interested in seeing how can we use ChatGPT or similar large language models in healthcare. So this is just last year from our 2023 analysis. We found that a lot of different specialties are already publishing. They're doing research and they're already publishing, trying to address the question of how can we use this for their own specialty. Of course, as you see, the opportunity is ripe for critical care. We are a little bit behind, but I think we could leap forward in this too. So let's start with asking some basic questions. Can these algorithms and can AI guide safe clinical decision making? And this one you will relate to because it's close to what we practice, what we take care of every single day, that is sepsis. So in this particular publication, what we saw was, and this is actually a model that is commercially available in the United States, at least. What they did was they made sepsis alert essentially, and they made the application of that sepsis alert integrated into the electronic health record. And if these alerts were followed in a timely manner, what they found was that there was lower mortality amongst the patients. There was decreased worsening or decreased deterioration in the clinical deterioration in these patients, as seen by the SOFA progression, and there was decreased length of stay. Now, what this tells us is outcomes can be impacted by implementation of these algorithms. So that was an important step, and especially for sepsis, which is extremely complicated. And same thing in anesthesia, and this is also being trialed in critical care areas. There was this development of hypotension prediction index, a very interesting algorithm that they developed, which is based on pulse waveform, pulse contour waveform analysis. And you think about the cardiac cycle, which has the representation of the pulse. And a lot of us, especially I would say many of the old timers, they will always say, go feel the pulse of the patient. It tells you a lot. That is true. And that is exactly what this science is trying to do. It tries to feel the pulse of the patient through the arterial line. So it's looking at the arterial waveform. But what it does different is it looks at a lot of permutations and combinations, which are called features. So more than 2.6 million features were analyzed. And then they created this machine learning model with some selected group of features, which can predict hypotension 5, 10, 15 minutes ahead of time before it occurred in a patient. Now, typically we feel the systole, typically we might feel, the different aspects of it. But when I say features, it might be the height of the systole minus the height of the diastole. It might be the height of the systole divided by the duration of the whole cycle. A lot of these computations we don't do and we cannot do in real time. So they looked at 2.6 million features. to figure out which ones matter. And that is the benefit of high degree or sophisticated computation that AI can do and is makes it applicable. So here's an example of this in a patient that they gave, where you can see the hypotension prediction index at the bottom increases. So it's predicting that hypotension is going to occur. And you can see at the top the mean arterial pressure, which is slowly going down, and it's alerting you many, many minutes ahead of its occurrence. And as I said, this is being trialed in critical care areas too. It's available through a commercial device, and it's in application in the United States and many other places. But here is the question: will clinicians follow the guidance? So this is a study that a few of my colleagues did at the Cleveland Clinic. We looked at this particular algorithm, we trialed it, and what we found interesting was that only half of these alerts were followed by the clinicians. What they found was if you had followed these alerts, the guidance was correct and would have been associated with decrease in hypotension, but only half of them were followed. And the question is why? That is something that we are still trying to understand. That is what we are still trying to learn. Is it just that it's not explainable, that we don't understand it well? Is it just because we don't want to believe in it? Is it because the human computer interface is not good enough? The way that it shows the information is not good enough, and I need to know more? There is a lot of science that is related to human adoption of these algorithms and the guidance that is also being researched as we do this. And I said, a lot of these have not been without challenges. So a lot of people have challenged the science too, which is a good thing. That is what we do. That is what the clinicians and researchers should do. So there has been some challenge. There have been some challenges that have been made to this, looking at the biasness in the algorithm and then subsequent rebuttals. So don't just take it at the face value. Don't just accept it because it's AI. We have to do what we have been doing for a long period of time, trying to understand whether this is correct science or not, whether this is there are any caveats to this, whether it's applicable to my patient population or not. And that's the best way to adopt science. We are seeing these trends also in other specialties, as I had mentioned previously, which impact us. So automated echocardiography. So classically, echocardiography is done by the cardiologist, but with focus or the point of care ultrasound growing in its use in critical care over the last decade, we are seeing the adoption of these algorithms that are being embedded in echocardiography devices. And what we are seeing is that these AI algorithms can predict things like ejection fraction as good as board certified cardiologists. And again, it's a deep science. So it looks at the image, and there are these neural networks through which it can predict what the ejection fraction is. So it's not just somebody trying to do something magical in there, but there's a deep science related to this. And what's amazing is to see the adoption of some of these echo devices, which are AI enabled. Here is a very interesting study where they looked at nurse who is not trained in performing ultrasound or echocardiography. They gave them an AI-enabled echocardiography device. And they compared that against a sonographer who is trained in obtaining images. And what they found was for most of the images related to echocardiography imaging, they were comparable. So think about now nurses or other people who are untrained in obtaining images with these AI-enabled devices could get at least the images as good as sonographers, democratizing these key skill sets. We are all challenged with the limitation of workforce. There are only so many intensivists. There are only so many intensivists who can do ultrasound at a particular time. But the patients can deteriorate at any point of time, can deteriorate at any location. What if these AI-enabled devices help a lot of untrained people acquire at least the image, and then we can interpret and provide the right care to the patient? That is where democratization of certain key skill sets using AI becomes very, very critical. And we are seeing these examples in developing countries. So we are seeing these examples as in areas of Africa where there are very limited healthcare resources, but then ultrasound is being used for pregnant patients by people who are not necessarily medical trained, but they can at least help with diagnosis, which can lead to better care for the patients. So in large country like India, where there is varying level of care, and in US too, these are great solutions that can help get better care for our patients in the future. And same thing, here is what we saw, novices versus experts in ICU. So think about your trainees. So think about other people who might be practicing in the ICU, even the internal medicine physicians who might be readily available on the floor, but you may not have a critical care physician readily available on the floor to perform an echocardiogram. Think about all these other people who become an extension of you, who can at least get you some basic information through which you can do decision making. And again, this is something which is very complex. Training people for echocardiography is very complex. So if that can be enabled, then better care can be provided to patients in a much more effective manner. This is something that we did a few years ago with Carnegie Mellon. We were trying to see if the electronic medical record, because we constantly feed the data into the electronic medical record, or we are constantly writing notes, but we are not able to extract the information out of them very well. So this is an example of where we looked at trying to infer diagnosis out of these clinical notes. Because it's a challenge. Trying to summarize that is a challenge. And of course, we built this machine learning model through that. And we found that with a great degree of accuracy, you could do that. So you don't have to necessarily write down all these diagnoses. It simplifies it for you. And it can tabulate the diagnosis for you as long as you have a note. It can read your note and try to infer these diagnoses with high degree of accuracy. Of course, there are more sophisticated models now. We probably would not use the same model anymore. The other example I'm going to show you is the clinical variation that we see. So I might practice one way, another person might practice another way, and we see this unique practice patterns. But sometimes we can't tell why is this practice pattern more effective than the other practice pattern. Sometimes we call it experience, sometimes we call it the art of medicine. But what we wanted to understand using AI was what are these variation in practice patterns which can tell us about these different cohorts. So here, we put all the data related to a lot of these colorectal surgery patients, and we wanted to see the two cohorts, one who did very well and the one who didn't do so well. And we wanted to understand what were the different practice patterns related to that, including cost. Why is the cost high in one group versus another group? You try to do that manually, it's very difficult to do that. It's very labor intense. You'll need hours and hours of going through the records, through a lot of data, even if you have it, to try to understand that. But we already have the data. It's just the analysis that is challenging for us for do. But that doesn't mean that we don't do it. AI can enable you to do that and can take out these practice patterns that you might want to follow, which we call best practices, or sometimes evidence-based medicine. Now, here is another example that I want to show you about listening to our patients better. So one thing I felt great about my mother's care at Yashoda Hospital was that there were unique things that I found at Yashoda. There was very personalized care. There were excellent clinicians. And later on, I did put in a Google review. And I put in the Google review about our experience. A lot of people are writing these reviews, right? And when you think about where to go for dinner, you look at some of those Yelp reviews or other reviews, and you decide where to go. Similarly, patients are also looking at these reviews, and they are trying to make their decision which hospital they want to go to. So in this particular case, we wanted to see if we could take a lot of these comments, and instead of doing manual reviews, can we sift through these? Can we analyze these using AI to understand where patients are saying there are opportunities for improvement. So if you are doing great, that's great. We want to continue with that. But if there are opportunities for improvement, then how can we infer those and group those so that we can do systematic improvement in those areas? So what we did was we took 15,000 comments, put it through this AI algorithm that we built, and in less than 1 minute, it could tell us the key opportunities for improvement. And then you can take actionable steps. Now, the beauty of using AI in this is we actually tried to do this manually using 4 residents. It was a resident quality project. It took us 4 months to get a similar analysis. Now, you can do it manually. It'll take you a lot of resources. Now, you did that, and you get a set of opportunities for improvement. And then you make certain changes. But then once you have made those changes, you want to measure again, right? Did anything improve or did anything change? Now, to do that, you will again need a lot of resources if you're going to try to do that manually. Whereas over here, you can feed those comments right through the AI algorithm, and in less than a minute, even if it's more than 15,000 comments, in less than a minute, it'll tell you, yes, the trends are improving or the trends are worse. So we can use this to listen to our patients in a better way. What are the patients saying? Do that better way. And here is another interesting publication that came out recently, because that human touch, that human empathy, that I actually felt that my mom and our family received over there, that cannot be replicated by computers. But here's a publication where they showed that if the chatbot was asked a question or a physician was asked a question, the response that was generated by the chatbot seemed to be more empathetic. Now, everyone knows computers cannot have empathy. We know that. So what was about it that made the chatbot response feel more empathetic? And one of the things was that it was more verbose. The response had more words. The response was structured in a way where it appeared more empathetic. Whereas physicians, we are busy, we might just type in a sentence or two, and patients might feel that, well, it doesn't carry as much empathy. It's just trying to give me a response rather than carrying any empathy. So can we take the physician response and have the chatbot make it more verbose so it carries the physician's empathy through? Because we are all empathetic, that is true. But can it help us structure it in a better way, or our response in a better way? And that's what a lot of people are trying to use AI for. Commonly asked thing as well, yes, it might be able to look at sepsis based on the data. It might be able to look at different practice patterns looked on the data, but AI cannot help me do procedures. And that's where it's a problem. Well, that's not necessarily true, because what we're seeing is AI applications which are helping with procedures. So on the left, you can see this ultrasound guided robot, which uses AI, which can help with difficult venous access. So you think about all these patients who have difficult venous access. We poke them sometimes many times. What if you had a robot that could help you with that? That would help us save a lot of time and pokes. It would help the patient so that they don't have to be poked multiple times. So these are being trialed, these are being developed. This is what's coming out. On the right side, what you see is an example of AI-guided pain block. And this is an FDA-approved algorithm now, where the needle trajectory is guided by the AI. And what it does is it helps improve the margin of safety so that it's not an intraarterial injection, or it improves the performance of the block because you're depositing the local anesthetic at the right place so that it's more effective. So we are seeing that AI can actually help with a lot of procedures to not just sift through data, not just look at diagnosis, but also help you with procedures. The echocardiography example that I showed you, there are 4 FDA-approved AI algorithms for determination of ejection fraction. So it's real. And if you see FDA-approved AI algorithms over time period, these are only increasing. for all healthcare specialties. Predominantly, they have been there for imaging. So in critical care, for example, when we get a patient with stroke, and many times you don't have a neurologist readily available, the CT scan can be interpreted for stroke or not stroke, for large vessel occlusion or not, so that the intensivist can help make that decision about what to do next, or whether to consult a neurologist or not. So a lot of these devices are real. They are getting FDA approved, 600 plus FDA approved AI enabled devices out there, or algorithms out there. So this is real. This is happening. These are in application at many centers, including India. There are many centers that are using this. And again, to make it real for you, it's not just that they are being implemented in clinical care, they're also getting reimbursed, at least in US. So you can bill for those in US, and you can see some of these examples where they're using this for various different purposes, whether it's for diagnosis of diabetic retinopathy, for liver MRI, for quantification of the tumor, for liver MRCP, for arterial plaque analysis. For a lot of these things, it's actually getting paid for through the insurance company. So AI is not the future, it's happening and it's real. But it also needs to be evaluated. And that's where there are a lot of evaluation frameworks that have been proposed. And that's where a lot of us can contribute who don't necessarily want to be deep into the technology. So if you think traditionally, we are involved in these randomized controlled trials for medications or devices. We don't necessarily get involved in the development of those drugs or devices, but we do get involved in the evaluation of these devices. So similarly, there are a lot of evaluation frameworks, and that's again an opportunity for a lot of us to participate in. And think about a lot of AI that is being developed in US and other places. But is it right for the Indian patient population or the Indian use case? And that's where they need to be validated for that patient population. And that's where, again, we need to lead that work as clinicians, just like we have done it for drugs and devices. So a lot of frameworks that are being proposed to do this evaluation. It's good to learn and it's good to get engaged, even if you don't want to get engaged in the technical part of it, but in the evaluation part of it. And again, recommendations that we put together for perioperative care, they're true for critical care too. We can get engaged in the AI space with education, trying to collaborate with different groups, trying to assess the data quality and access, algorithm validation, just like I said, the implementation aspect of it. Why are we failing in its implementation, or is it right for implementation? And then regulatory advocacy, because we want to hear all the voices. We want to make sure that any concerns are heard and addressed, and we are not just taking it just because it has AI. So here's the question: should you do it yourself or try to collaborate? Should you start trying to make your AI algorithm yourselves or not? So there's some guidance that we gave in this particular paper some time ago. But more important than that, in critical care, we all are challenged by access to data, which we already access in our clinical life. But what I want to show you over here is there are a lot of data sets that for critical care, specifically for critical care, that are readily available for you to do your research work or development work. The MIMIC dataset, Amsterdam dataset, EICU Collaborative, all these datasets are open source. They are available to you. These are ICU datasets specifically. And you can do your research work starting today. You just need to sign a minimal data use agreement that is very straightforward, that you won't use it for wrong purposes and stuff like that. But you could start using this today. So you don't have to wait for Yashoda Hospital dataset or your particular Indian dataset to come by in the next few years. You could actually start working on this today. The other opportunity is the datathons. So there are a lot of datathons that are occurring. This is an example of a datathon that I participated in. And we built a team. we had computer science graduates, we had clinicians, we all got together. We were trying to address a particular question. We did this in 2 days, and 10 months from there, we actually published it too. So there are a lot of these datathons that are also happening where you have an opportunity to participate, learn about this science, not necessarily do everything yourself, but do it with a team. And that's why that question, should you try to do it yourself or should you have a team to work with? There are all these opportunities. And similarly, last year, our team won the uh, European Intensive Care Medicine Datathon. And we looked at the power of causal inference, looking at mechanical power. So at what point of time is the mechanical power causing harm to the patient? That is what we try to do through this. And the team had critical care physicians from across the US. And then we had team members from across the world who were computer science graduates. So a lot of these opportunities are ripe. And just recently, ESICM put out the information for this year's datathon. So you could go to the ESICM website and you could participate in that, build your own team. And Hyderabad is the right place to do it. You have all the great data science people over there. You could build a team and participate and win the datathon too. But there are still a lot of challenges. I said, data is a challenge. I showed you examples of how to overcome that. The quality of data is a problem. There are a lot of regulatory concerns which are real. You don't want patient data to be out there. There is lack of knowledge. That's why this webinar is very helpful, trying to help people understand what is AI, what are the opportunities of it. Not trying to take a deep dive, but at least get you started in your journey. Then the lack of unified approach as in the technologists are trying to do something by themselves, and we are trying to do something by ourselves as physicians. Can we have a unified approach which helps our patients and helps our purpose? And I think that's a great opportunity for us. And of course, there are a lot of ethical concerns and legal concerns. I tell you, I get a lot of calls from very exciting, very talented people in India who are trying to build these AI algorithms and they need physician partners. That's a great opportunity for us to get engaged and for us to lead that work. That actually helps us because otherwise it's hard for them to do it by themselves. They don't understand all the medical terminology, they don't understand the implementation aspects for it, but it's a great opportunity for us to work with them and put a unified effort. A lot of people are concerned that will I lose my job? So Jeff Hinton, who is considered the godfather of deep learning and AI, a few years ago said that medical schools should stop training radiologists because it's very clear that X-rays and CT scans and all these things will be read by AI. Well, that is not true. So I looked at the data, and it turns out since he said that, the number of radiology programs in US has increased, the number of spots has increased, and I can tell you for sure that the number of radiologists that are needed has also increased. So there's a huge shortage of radiologists. So what he said was not true, but it also defines the opportunity for us. The opportunity is radiology has been spearheading this work. They have their own journal for AI. They've been doing a separate conference for AI. They have dedicated training resources for AI. And I think that is where critical care as societies, and we are seeing examples of that through these datathons and various different resources. Along with Dr. Stevens out of Hopkins, we formed the data science section at the Society of Critical Care Medicine. So if you're a SCCM member, you can join that for free. It's called Data Science KEG, KEG. You can find it on the SCCM website. And we try to provide a lot of resources and exposure to data science and AI through that. And that's an opportunity for critical care to work together, to collaborate together and build more. But again, beware of the hype, because there is a lot of hype about it too, and it's real. There is a lot of money chasing this too, and we need to be cautious about it. That's why validation is extremely important. Validation before using it on patients is extremely important. Validation, not just in US, but in India, on Indian patients is extremely important. And the opportunity for us is to build these companies, to build these collaborations that will bring AI to bed space. So Andrew Yang is a professor at Stanford, and he said that AI is the new electricity. He's the professor of computer science over there. What I say is that we need these partnerships to build energy companies. So hope this excites you. This gets you thinking. This gets you thinking about how to partner with some of your local technologists or across the world, and how you can develop this in the future. Now, some of the cases that I showed you were examples of using a simple type of data or a simple or a single type of data or a single type of model. What's coming next is and these models which can take different types of data, not just the data that is text or imaging, but a combination of different types of data and try to answer a lot of these questions. So this is an example that came from Google. It's a multimodal model. You're seeing similar models come out in ChatGPT and others, where it can take different types of data and still be able to answer different questions for you. That's happening in healthcare too. And here is an example from University of Michigan, where they combined the waveform data with the other physiologic signal data in the from the electronic health record and devices, and were able to predict which patient post-operatively after cardiac surgery is likely to deteriorate. So we are seeing this happen and being researched and being developed in our critical care area too, or perioperative area too, which is very, very exciting to see. So to conclude, algorithms or in critical care or perioperative medicine are not new. So you think about all these algorithms that guide pulse ox, that the systolic volume variation. A lot of these algorithms have been there for the longest time when we have been using that. But these more sophisticated algorithms are coming about. For us, it's to make sure that we should champion the validation of this for sure. Clinician leadership is extremely important. That's why this is a call for all of us to get engaged and collaborate with the engineers. As I showed you, some of the evaluation frameworks are already there, and adoption of those are key. I always try to ask this question, can AI save lives? And this is the picture of Gene Kranz. Gene Kranz was the mission controller for Apollo 13. And imagine that spaceship was stuck trying to go to the moon. And they had, when that spaceship was stuck, he was a mission controller who said failure is not an option and brought it back. We are safe on Mother Earth, and I think it's for us to make sure that we adopt this science in the way that we want it adopted to help our patients. So thank you very much for the opportunity. We'll be happy to take any questions.
Yeah, thank you very much. It was an excellent overview of AI. So what we actually try to understand is in Indian context, if you look at an Indian context here, we are still evolving in many electronic medical record. What will be the EMR's role in the context of AI in critical care?
Yeah, EMR's role in United States and some of the developing countries has been critical. So the reason why a lot of these AI algorithms have been built is because of availability of digitized data. Without digitized data, it's very difficult to develop this. So the role of EMR has been critical. But what we are also seeing now with these better technologies, with OCR technologies, with OCR with GPT, with other technologies, is that you have the opportunity to take the non-EMR data and be able to use that for this purpose, for development of AI tools. So it can extract data out of even paper records. And we are seeing examples of that in India itself. I know of one critical care group that uses the EMR data and is able to do that, that is extract the information either from the device itself, looking at the device itself, or from the records, which are paper records, and then be able to do the analysis. So in many ways, the opportunity for India is to see how can you adopt these technologies without using EMR? And there are examples of that that are being looked upon in India itself, and solutions being built in India. So, in India, we say like there is this very famous word called jugaad, and it essentially means innovation in many ways. We're trying to innovate and we're trying to leapfrog many other countries. And maybe that is the better way. Maybe that is the more cost-effective way. Maybe that is the more clinician-friendly way to do it. So we have to, in India, figure out our own solutions, not just necessarily think about what some of these developed countries did. I can tell you, EMRs are very expensive. So do we need that? Can we do it another way? That's what we need to think, and that's where we need to innovate ourselves in that area.
So there were questions related to limitations. You already mentioned about few of them, but what are the limitations of AI right now?
I think we are discovering a lot of those. So one of the key limitations that we see commonly is bias. So AI is typically trained on a particular data set, and it may not be extrapolatable to another area or another field. So let me give you an example. There was a very good publication that came out in Nature, and that was involving Google's research team. What they did was they took the VA, which is the Veteran Affairs data set. It is essentially the Army's data set over here in US. And they built a AKI, acute kidney injury prediction model.
Okay.
And it was published in Nature. So you would say like, well, Google did it, published in Nature, so it's great. And it had a very high degree of accuracy in predicting AKI 12, 24, 48 hours ahead of time. The caveat to that was that that data set, as you can imagine, is predominantly male data set. It's predominantly Caucasian male data set, that is white male data set. So then people looked at that a little bit deeper, and you cannot use that algorithm in a patient population that is not Caucasian male. When they looked at that algorithm and trialed it even on female veterans, even then the performance decreased. So just because it comes from Google and it's published in Nature doesn't mean that it's necessarily the best. You still need to dig deeper. The same thing with hypotension prediction index. I think there have been challenges made to that about the biasness that might be there in the development of that. The biasness is one of the key issues, and that's why validation is extremely important. But again, I want to caution there too, because these algorithms which are developed, can be adopted, can be modified for your use case. So don't just throw it away. See how can we modify it for your use case. Can you use your data to fine tune it for your particular patient population and your purpose? But that is a huge big problem. The second big problem that we're seeing is limitation of understanding and resources. So if you go to your IT team and say that, hey, I want to implement this AI algorithm, not everybody understands how to do this. So that's why educating everyone, building these teams, building these groups, and providing the resources is extremely important to bring it live to our bed space.
There's another interesting debate always. Who will be medical legally liable if a AI guided algorithm has been followed and the patient got some complication or some error there?
Yeah, I think the debate goes both ways. The debate is who will be liable if you use it and if it gives you wrong information. But what if you were not to use it and it was giving you the right information? So it actually goes both ways.
Okay.
And currently, the way it stands is that it's all these AI algorithms are being approved as clinician decision support. So ultimately, right now, the burden is actually on the clinicians, at least in the United States. And I think there is a lot of work that needs to be done in this space. The legal community is also very excited about it. Excited because they see a lot of legal cases coming with the adoption of these. But they are also trying to understand what does it mean. And sure, I think the liability will ultimately, I believe, be differentiated between where the issue was. So if the AI algorithm itself was flawed, then I think ultimately the liability will go to those companies that developed it. But as it stands today, it is clinician decision support. That's how these are labeled. And ultimately, right now, it stands on you. But you think about like all the drugs or devices, and there have been medical legal challenges placed to them. And it's not necessarily the physician who is always held liable. If there was an issue with the drug or how the validation was done, those companies have been held liable. So I think in the future, that is how it is going to be distributed, whether it is a user issue or whether it is a algorithm issue. But that more to come on that.
But you raised a very interesting second part of it. If the AI is suggesting something and you didn't follow it because your protocol or your clinical equipment didn't support, is it true right now in United States that you need to go through a AI algorithm? How do we actually say, okay, AI has guided this? Do we take all the cases AI help there?
No, and the example, that's why I showed you the trial that we did over here. Uh, Half the guidance was not
Guidance.
followed by the clinicians. And there are similar examples of those too. So right now, it's all left to the clinicians to whether they want to accept that or not. But medical legally, I think this is going to unfold in the future where it's going to be challenged that, okay, it was giving you, it's like the warning. You think about that aircraft that is there, it's giving you warning, or you're driving a car, it's giving you warning that the gas is finished or the tire pressure is low, and you ignore it. You keep on ignoring it because you believe that is not true for whatever reason. Who should be liable? Ultimately, whether it was a flaw in the warning, maybe it was giving you a false warning, then yes, the car company should be liable. But or the aircraft company should be liable. But if you ignored it when it was true, just because you thought something, then I think you are likely to be liable.
You actually brought the interesting topic about losing jobs as we are talking about the imaging, radiology, or in other forms where AI is used, not just in medicine. But do you think this AI will take away the human intelligence interpretation or role because everything will go through algorithm or AI-based treatment? So your use of your intelligence or individualizing each patient care will go into a tussle nowadays after a lot of seniors talking to us. You lost the clinical acumen, you lost the human touch, you lost the examination skills. This is not uncommon statements we see at the bedside from our senior colleagues. Is it going to also affect that?
I don't think so. I think that's where clinician leadership is very important. When I receive a patient from the operating room to the ICU, one of my first examinations is touching their extremities. It gives me a lot of information. Their extremities are cold. That means that they still might need more resuscitation. Still look at their pulse, still look at their pupil, and do that. Despite the monitors, despite those non-invasive cardiac output devices, despite the echo, we still do that, right? So I think these devices are only going to give us more enhancement. I'll give you two examples of this. So you think about the radiologist. The radiologists in their prior days used to only look at chest x-rays. Now they're putting these coils or these stents, which used to require open surgeries. And previously, patients had to stay in the hospital, and these surgeries used to be done by surgeons or cardiac surgeons or cardiologists now, or vascular surgeons. Now radiologists are doing them. They're putting in these coils or these stents. Patients go home the same day or next day after that. So they have evolved. Similarly, I think we will evolve. I think the things that we were able to do previously will not remain the same. That part I agree. The other example I'll give you is when I started, there was no ultrasound in the ICUs, or not as much ultrasound in the ICUs, I should say. We used to do pretty much manual estimation of where the IJ is and put in these central lines. With the ultrasound, do we think it has become safer where you can visualize it and do that? Most of the people are using ultrasounds. It's standard of care in US at least to use ultrasound for these. And it has actually made it better and made it easier. It has made it better and easier for a larger group of people also to do it more safely. Even the trainees feel more comfortable doing it rather than doing it blindly. The same evolution you're seeing in critical care, moving away from the traditional laryngoscopes to video laryngoscopes. It's enabling better visualization, and you're seeing the outcomes improve with that too. And people who previously had more challenges getting the airway are able to do that. The same way I see that there is likely to be an evolution in this, where these AI devices are going to provide enhancement to us, but it's not going to take away from our basic assessment. And that's why the number of radiologists hasn't gone down. It has actually increased. So there are radiologists who are adopting AI, but you need more radiologists because it's giving different inferences, it's giving you different patterns, it's giving you different ways of diagnosing things. And that's why you actually need more. So I don't think the job is a threat. The way we do things, yes, you may not stay or do the same thing as you used to, but that is natural evolution either ways. We are doing things different compared to how we used to do 20 years ago.
There are few areas where there is already, as you said, the use of AI been happening. So one of those areas I believe is mechanical ventilation, as you said, also been involved. So do you see any evolution in the mechanical ventilation, the way we do see, we talk about mechanical power, we talk about driving pressure, we talk about many things putting together. But do you see the AI may play a better role in suggesting a modality or predicting which is the ideal PEEP or ideal way of ventilating a patient?
Yeah, that's a great question. I think that this is something where we're a little bit behind because a lot of research has been on the cardiovascular side. But on the mechanical ventilation side, we're still behind on this, and that's a great opportunity. That's a great opportunity for all of us to do it because if we are behind, then we can catch up with that, and it's an opportunity for us. I think there are many ways to look at it. One is the inference of the waveforms itself. A lot of people struggle with that. Like, okay, you see the waveform in the ventilator, what does it mean? What does it imply? A lot of people, including in education, in teaching the trainees, that this is what it means. This is auto PEEP. This is where the patient is triggering the breath. So can that be automated instead of you trying to guess and trying to figure out what it is? Then some guidance for what might be optimal for a particular patient, because we have always, based on ARDSNet or trials or other studies, gone with some very simplistic approaches that this should be the maximum plateau pressure, this should be the amount of oxygen given to the patient or the FiO2, this is how much PEEP is there. We still struggle with optimal PEEP. Partly we struggle with optimal PEEP, I believe, is because it's the variation in patient condition and the variation in patient population. So that's why we struggle with it. So I think those areas are ripe for application of AI, where it might help us guide better. And the last one is the weaning part of it, the weaning protocols. Can it accelerate the weaning for many of the patients?
Yes.
And can it enable, nurses or other clinicians to become extension of us? Because they shouldn't have to wait for us to come to bedside to start weaning them. Can we accelerate the weaning, or at least do a weaning trial before we arrive and get the parameters, and then we can do the decision making whether the patient is okay for extubation or not. The last is looking at the ventilator patterns and the ventilation patterns with other things that are happening. So that cardiovascular, because we know that we think about the VQ shunt, it's not just dependent upon how you mechanically ventilate the patient, it's also dependent upon what's happening with your hemodynamics, between your dead space and the shunt. So can it correlate with all that and give us a better understanding of the PO2 to FiO2 or other things that we're trying to estimate? I think all these are ripe and all these are great opportunities for us to get involved in and think about.
You said the hypotension prediction was happening in a perioperative period and all that work. Does it also help say in phenotyping? Now we are talking about phenotyping ARDS, phenotyping sepsis, looking at all those parameters, and yeah, so does it also can be a guide in the future of phenotyping this ARDS and sepsis?
Oh, absolutely. And that's what we are seeing too. And that's why I was trying to show you that example that we did over here with the cohort analysis. Can we look at different cohorts in a different way and then phenotype them differently? We are seeing that with sepsis. We are seeing that with ARDS. We are seeing that with heart failure and many other diseases. So it's very interesting. We are seeing a lot of research work that is coming out looking at EKG, but then being able to predict from a normal EKG who's likely to develop AFib. So not just phenotyping a disease itself, but also phenotyping patients who are at risk for a particular disease. So we are seeing a lot of this research work that is going on. It's partly because of the patterns that are there that are humanly very difficult to compute, but a machine can compute it better than us.
There were questions related to clinical judgment of physician will prevail over AI in caring a patient.
Well, that is currently the standard, and that's where clinician leadership is extremely important. That there is no autonomous AI that is there available for decision making right now. There is only one or two that are for screening purpose, diabetic retinopathy screening. But other than that, there is no autonomous diagnostic AI. It's all supporting clinician decision making. So I don't at least see in the near future it replacing us. Can it provide an extension of us? That's what we are looking to see. Can it provide different information or better information through so that maybe a larger workforce can be enabled to provide better care, just like I showed with the echocardiography example. I think those are more likely rather than the worries about replacing us or replacing our decision making. I don't see that happening in the near term.
So is the clinical decision making support system is a mandate in US, or it is states, or it is just an optional option?
Yeah, it's still an optional thing. It's just providing you the guidance. It's up to you whether you want to accept it or not.
You had an interesting component of focus in ICU and AI integrating it. So once image, you get an image, you can have some AI interpretation, but the error is actually getting an image. Does the AI also helps in getting an image, guiding a
Yeah, yeah, that exactly was the example that I showed. So you had the novice nurse who's not trained in echocardiography versus the sonographer. In US, we use the ultrasound or sonographers who obtain these images. If a novice nurse was given the AI-enabled device, they were able to obtain the image with the same level of accuracy as a sonographer. So obtaining the image, yes, that was exactly the example that I was trying to show.
it keeps on guiding. It keeps on guiding the position of. Okay.
That's right. So if you think about it, what is echo or ultrasound based on? It's essentially Doppler principle. You think about the cardiac echo or that is there. You think about the point of maximal impulse for old timers like me, who still think of PMI. You still think about where it needs to be. The beam needs to be directed for what type of image. A lot of those principles are true when you see with the use of echo, and AI can help looking at that data, looking at that sound, looking at the waveform that is coming, and then guide you how to manipulate it. And the other example that I showed was if you're doing a pain block using ultrasound, it can annotate the tissues, that this is the different layers of muscle, so that you can have your needle trajectory go accordingly and be able to perform the block much more safely. So yes, it can help. It can help. And by the way, these are FDA-approved devices that are readily commercially available.
Thank you.
So it's not future, it's present.
So I think thank you, Dr. Piyush. It was an excellent explanation to all these queries which have been commonly discussed, interacted. And we are all happy to listen to you in the future also in maybe a particular specialized area like focus AI or mechanical ventilation AI. We'll go into a little more details. And thank you very much for your 60 minutes plus time to catering us and probably taking your valuable time out of your schedule and helping us in learning this. We thank you for being with us, and I thank all the participants and audience who are the part of it. And I conclude the sessions. Thank you, Dr. Piyush.
Thank you. I hope